Premiumbeat.com. 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 Premiumbeat.com.
Welcome to Advancing the Dream webinar series, and thank you for joining us today for Health Equity in the Time of COVID. At the Milken Center for Advancing the American Dream, we see equal access to education, healthcare, financial empowerment, and support for entrepreneurs, all as essential underpinnings of the American dream. Our visitor center is going to open in 2023 in Washington, D.C., but in advance of that, we're building a robust online conversation around issues relating to the American dream. With this series, we're seeking to explore opportunities to broaden access to the American dream by bringing leaders together around critical topics and issues related to each of our 4 pillars. This first webinar is focused on health equity. Health equity is central to the Milken Center for Advancing American Dreams mission, and we seek to encourage individuals, businesses, and government to do more to broaden access to health and wellness across our nation. The pandemic has highlighted how much work remains to be done and has brought to the forefront the significant challenges associated with unequal access to healthcare faced by historically underserved communities, as well as the impact of racism and other forms of discrimination on public health generally. We're excited to convene this distinguished group of panelists with the ultimate goal of identifying concrete, actionable solutions for addressing issues of health equity. We're also very excited to be delivering this program in partnership with the Milken Institute's Faster Cures. We could not have done this without you. Thank you very much. And now it is my honor to welcome our distinguished moderator, Jackie Adams, the author of A Blessing, Women of Color Teaming Up to Lead, Empower, and Thrive. Jackie is an Emmy Award-winning CBS News correspondent, and we are also very honored to say that she's a member of our advisory council, as is panelist Dr. Frida Lewis Hall. And thank you for bringing your talents to the stage today, Jackie, and I will now turn it over to you.
Thank you so much, Carrie. I'm honored to help lead this first webinar in the Advancing the Dream series. And since it is the first of our webinars, there was a little bit of a hiccup at the beginning, but we're so delighted to have all of you with us right now. As Carrie said, these Advancing the Dream webinars are designed to explore critical topics related to each of the Milken Center for Advancing the American Dream's 4 pillars, and to ultimately expand access to the American dream. Now, our topic today is big and it's complex: health equity in the time of COVID. Now, on the one hand, the past 14 to 15 months of pandemic have made crystal clear just how inequitable healthcare is in the United States. The American public has seen reams of unmistakable, undeniable data about the disproportionate infection rates, hospitalizations, and deaths among minority segments of the U.S. population. And this morning's headlines about vaccination rates said that the experts now fear that we will never reach the much hoped for herd immunity that, quote, widely circulating coronavirus variants and persistent hesitancy about vaccines will keep that goal out of reach. Okay, so the pandemic will never really end? Ugh. Over the past weekend, the New York Times published a long piece about the history of racism in the field of psychiatry. And some of that history was so heart-wrenching, so gross, that the American Psychiatric Association issued a first ever apology for its racist past. And it did that in January. But on the other hand, in the aftermath of the social and racial justice movements of the past year, a great many organizations and corporations have publicly pledged their support for change. Now, today we have a panel of very wise and very generous experts who are going to help us do 3 things. We're going to analyze the size and scope and reasons for America's health inequities. 2, we're going to discuss some current efforts to redress some of those inequities. And 3, as Carrie mentioned, we're going to propose some specific, pragmatic, yet moonshot remediation solutions that everyone in this audience can help affect. We're going to chat for about 45 minutes until about 2:30, and then save the balance of our hour together for questions from you in the audience. And you can type those questions at any time into the Q&A box. Before we begin, just to sort of set the stage a bit, I'm going to talk about the phrase health equity. What does that really mean? 4 years ago, the Robert Wood Johnson Foundation crafted a very optimistic definition of health equity. And they wrote that health equity means that everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs with fair pay, quality education and housing, safe environments, and healthcare. What a nirvana. So we know what health equity is or should be, but what about health inequity? Less than a month ago, CDC Director Dr. Rochelle Walensky spoke plainly and declared, quote, racism as a fundamental driver of racial and ethnic health inequities in the United States. The most recent evidence, she said, included those higher rates of COVID-19 infections, hospitalizations, and deaths that I mentioned earlier. But she went further. Quote, the disparities seen over the past year were not a result of COVID-19. Instead, the pandemic illuminated inequities that have existed for generations and revealed for all of America a known but often unaddressed epidemic impacting public health, racism. So if we rip the Band-Aid off our language, what we're really discussing today is racism in healthcare. Now, I'm going to give very brief introductions of our most distinguished panelists, all of whom are, as we say, lettered up. Dr. Frida Lewis Hall is the former Executive Vice President and Chief Medical Officer of Pfizer. In 2010, Dr. Lewis Hall was appointed by the Obama administration to the first of a series of positions driving patient-centered outcomes research. Dr. Lewis Hall received a Bachelor of Arts and Sciences from the Johns Hopkins University, and her medical doctorate is from Howard University Hospital and College of Medicine. Dr. Torian Easterling serves as the first Deputy Commissioner and Chief Equity Officer in the New York City Department of Health and Mental Hygiene. He's a community physician committed to health equity, social justice, and movement building. Dr. Easterling holds a Bachelor of Science from Morehouse College, a Doctor of Medicine from Rutgers, New Jersey Medical School, and a Master of Public Health from the Icahn School of Medicine at Sinai in New York. And Ms. Esther Krofa is the Executive Director of Faster Cures, a center at the Milken Institute. She has deep experience in the government, nonprofit, and for-profit sectors where she's led efforts to improve the lives of patients. Most recently, she was the Director of Public Policy leading GlaxoSmithKline's engagement with the U.S. Department of Health and Human Services. She received her BA from Duke University and a Master's in Public Policy from Harvard University's Kennedy School of Government. I said they were lettered up. So welcome, everyone. Let's start off with a quick sort of level-setting round robin. Were you surprised or shocked or relieved by Dr. Walensky declaring publicly that the known but often unaddressed epidemic impacting public health is racism? Dr. Lewis Hall?
So all of the above. I was surprised, I was shocked, I was relieved. I was also motivated and frankly a little bit nervous. So I was motivated because this acknowledgement, as difficult as it must have been to make, opens a door to action. And the action is to use the tools and resources that we know so well to address a public health crisis. And that public health crisis that we want to now address is racism. I'm also a little nervous, though, because the boldness of the acknowledgement and the courage that it took could easily distract us from taking the action. While we, admire the courage and are pleased and grounded that this acknowledgement has been made, I want to make sure that we take first steps and next steps to address these critical issues.
Great. Dr. Easterling, were you shocked, surprised, relieved?
Well, thank you. Thank you for creating the space, and thank you for hosting this conversation with the Milken Institute. Yeah, I agree with Dr. Lewis Hall. I would say that I was left with excitement because there's an opportunity to open up a conversation further for action, as Dr. Lewis Hall just mentioned. There are almost 200 locales who've already declared racism as a public health issue. And is a public health crisis. And I think the opportunity, as Dr. Lewis Hall really just laid out, is how do we move from the declaration and this acknowledgement to action? And so I would say that somewhat shocking is that not many of those locales, not many of these institutions have already prepared to lay out the actionable steps that they will take with the acknowledgement. And that's what we need to see. We need to see how are we understanding how these institutions have actually led to disinvestment and underinvestment. How are they acknowledging the wrongdoings that they have participated in? What are the areas in which they can think about resource allocation and using their data and their staff in a different way, and really doing some of the work of internal transformation. And so I think that's what we really need to see. I think the acknowledgement is an exciting step, but it really is about what can we do further.
Great. I hope that later in this conversation, we can talk about some of that internal transformation that may be happening in the worlds that you inhabit. Ms. Crofa, shocked, surprised, relieved?
I would agree with everyone, but I would actually say I was deeply relieved, took a bit of an exhale. I do think that these are issues that we've long known. Health disparities in healthcare is not new. It's not surprising. We've studied this for a long period of time. I think back even through my education, talking about these issues as an undergraduate, and certainly we've recognized that racial minorities, African Americans, Latinx, et cetera, have suffered disproportionately from a whole host of diseases for a long period of time, right? 30% more likely to die of heart disease, 60% more likely to be diagnosed with diabetes, 2 times more likely to die. Name your cancer, prostate cancer, breast cancer, cervical cancer, et cetera. And so I think for many people in the community, it was, a deep relief to see that acknowledgement. But yet at the same time, acknowledgement is just the beginning. There is a lot of hard work for us to do. And what I think about as this national reckoning really begins with every single organization, every institution, every body to look at, what can we do to really move the needle to solve for these problems? Again, given the fact that they're not new, how do we start to really think about this comprehensively, not just to have a Band-Aid solution, but to have really systemic, entrenched, and sustainable solutions?
These inequities may not be new to you, but they might be new to people in our audience. I've had a friend say, I just didn't want to believe that these kinds of disparities existed. But can any of you give us some direct firsthand knowledge of these inequities, things that our audience should know about? Dr. Lewis Hall?
So, I started trying to think about how to answer this, and I went through all of these articles, and it was just a litany of data on these horrible gaps in wellness, in morbidity, and in mortality. And then I remember that you said firsthand. And so I went through some of the experiences that I had treating patients and caring for them and looking at the gaps there. And what I decided to do, I'm afraid to say, is to talk to you about some of my first heart experiences. Did you know that African American women were 2 times more likely to have a stroke than white women and 1.3 times more likely to die? I know that. I looked it up. My mother died my freshman year of medical school in the summer of a stroke. Did you know that African Americans developed Alzheimer's at a rate of 2 times that of white Americans and have higher rates than almost any other racial group? I know that because my father recently died from Alzheimer's, luckily at the age of 100, but I lost my grandmother and my husband's mother to Alzheimer's. And did you know that African American men suffered from prostate cancer, were diagnosed with prostate cancer at a rate of 173 per 100,000 diagnosed per 100,000 men, and that white American men, 97.1 per 100,000. And that if you have sarcoidosis, like my husband does, you are diagnosed at a rate of 39 per 100,000 versus 5 per 100,000 for white Americans. So I have shared what I think are some shocking statistics about differentials in mortality and in having very serious illnesses. And they're not firsthand, they're first heart.
Well, you have my heart. Dr. Easterling?
Yes, certainly. Like Dr. Lewis Hall, certainly looked at our data and continue to look at our data. And, we shared our data very early on around this pandemic in New York City. And we saw very early on the disparities that existed. Black and Latino New Yorkers were more likely to be hospitalized and die from COVID 2 to 3 times more than white New Yorkers. Now, we can focus on those numbers, but I think it's really getting to the definition that you shared early on around inequities. And I think it's important to understand and root this in this social construct that we call race, and understand how racism plays out in these poor health outcomes. And so I think about Audre Lorde, who says that no one lives a single issue life. And so there's no single issue struggle, right? And if we're going to think about the work that we need to do, in New York City, we look at our data, and across New York City, there are 58 community districts. In the same community districts light up when we think about poor health outcomes, for social indicators, for economic indicators. And it's not because these neighborhoods, the individuals who live in these neighborhoods choose to. And I know this because I live in one of those neighborhoods. We understand that there is a systemic and structural inequity that leads to these outcomes. And so the connection of why a mother who is Black and has a child is going to have ultimately poor maternal health is also linked indirectly to some of the other issues related to economic, social, and that has really positioned families to not be able to reach their full potential around their health. And so we can show in New York City the same map that has diabetes prevalence, that also have COVID cases during wave 1, right? So thinking about March and April, and line that map up with the red liner map from 1930. And these are the same neighborhoods in the South Bronx, in North and Central Brooklyn, Southeast Queens, in Upper Manhattan, where we're seeing COVID deaths. So we have to understand that there is a link that to understand how these racist policies and practice have led to these outcomes today.
I have a friend who says that your zip code determines your education outcome, and clearly the same structure exists for health outcomes as well. Ms. Crofa?
As we look across all of these inequities we've been talking about, we certainly see it in biomedical research as well. It's not just where people have access to, get standard of care, but even in the research enterprise, I'm just struck by the fact that we still see in cancer clinical trials, for example, those even that the FDA uses for new drug approvals, only 2.3% of African Americans are enrolled in those cancer trials. We have about 82% whites that are enrolled in those trials. And essentially what that means is that we don't have the same kind of information that we need to have in terms of safety and efficacy, not just in cancer, but also even in HIV. I mean, again, I referenced the fact that, I started talking about health disparities and certainly studying it, as an undergraduate many years ago. But with HIV, this is an issue. It's been around for 30 plus years. We have further research going even into HIV vaccine trials. In terms of new diagnosis, we see about 42% of new diagnosis are in racial and ethnic minorities. And the only account in recent studies, 7.4% of those who are enrolled in those trials. And so, these are just two data points. A lot of these challenges are that those in racial and ethnic minorities are not asked to participate, or we don't have the clinical trials in the communities where people live. It's hard to go to an academic site. We don't have the appropriate level of health literacy or education around clinical trials. Not that you yourself might see the benefit, but that benefit of the research study can certainly happen for the entire community. And so that community is further left behind, and good science is further left on the table.
Thank you so much for that very specific and very personal list of inequities. It makes the subject real, I think, for our audience. I have to tell you, I was incredibly shocked by information that I first read about from a 2019 conference at Harvard's T.H. Chan School of Public Health called 400 Years of Inequity. And I cited some of this material in my book, and I'm going to just give you 3 points. A Black woman with an advanced degree is likelier to lose her baby than a white woman with an 8th grade education. Worse, certain stereotypes from slavery times have endured to the present, notably the idea that Black people don't feel pain in the same way that whites do, that Black skin is supposedly thicker than white skin. And this notion was used to justify whipping and other forms of abuse. And you might say, oh, how silly, how ridiculous. And yet, a 2016 survey in the Proceedings of the National Academy of Sciences of white medical students and residents found that half of the respondents still believe and act on these inaccurate beliefs. So there are so many ways to tackle this inequity problem. Dr. Lewis Hall, when we chatted last week a bit in preparation for this session, you said something incredibly provocative, that we have Star Wars medicine, but we have Flintstone healthcare. Well, what did you mean by that?
Well, our capability from a scientific standpoint is enormous. And research has shown that it takes 17 years on average for new scientific findings or new information in medical practice to actually be applied to patients. 17 years. When I first talked to somebody about that, they said, well, it took 260 some years for Lancaster's demonstrated ability to prevent scurvy from being adopted in the British Empire. I thought that bar was a little low for my liking. But the idea is it's always taken a long time for us to adopt new science on behalf of the people that we serve in health and medicine. And so a part of the way that I think about this is, how do you close the gap in adoption between the demonstrated confident finding that something would lead to a better outcome for a patient and this kind of broad adoption and application? So I have this vision, if you would, of the tricorder, so that we're personalizing our findings on each person, and that will allow us to help patients and their families make decisions using the best, most recent, and well-informed information. Got a ways to go on that, though.
Right. Several of you in our prep session described bright spots. I mean, there's so much death and destruction here. Maybe we can just look at a little bit at something that is uplifting. Ms. Krofa, you are impressed by something called NIH Unite. Can you tell us a little bit about that?
Sure. I mean, I do think despite all this really sobering news that we've been talking about, it's important to elevate what is happening that's going in the right direction. Dr. Francis Collins, the director of the National Institutes of Health, just recently announced in an effort called Unite, which is focused on ending structural racism in biomedical R&D, particularly an effort where there are going to be 5 committees across the 27 different institutes at NIH looking at ways to tackle and end racism in medical research practices. And data, of course, suggests that even within NIH's grant process, that African Americans, other racial and ethnic groups in particular, are disproportionately less likely to get NIH grants. The data suggests that in priority reviews, they score about 10 points lower. And so despite all of the efforts over the years to try to close this funding gap, it still persists. So NIH is taking a look inside to say, what can we do differently? How can we all come together and look at the data, look across our practices, look across our review committees, and end the racism and end the disparity that we see even in a grant giving process?
Do you think that'll reduce the 17-year gap between a discovery and a remedy getting to a patient?
You know, I think when we have representation at the table, scientists ask different questions, and we can get the right questions to be asked that normally we will not have access to the appropriate data and the information. And that might likely help us to get more effective treatments, better science for those who are affected. There's certainly a lot of challenges that lead in terms of that 17 years and barriers. But I do think if we start to ask the right questions, we'll see not only better products, but also better uptake by patients because they're actually doing things that matter to them. And so those are the things that are left on the table when we don't have the right voices represented.
Okay. Thank you. Dr. Easterling, let's get back to COVID. Again, were there any victories in the vaccine rollout here in New York? I have to tell you, I look at my New York Times online several times a day, and the exposure risk in my specific area is at a very high risk level. Do you see that risk level coming down anytime soon?
Yeah, so there's certainly been wins in our vaccine rollout. But as you laid out, we remain optimistically cautious about where we are at this time, continue to look at our data, but also matching what we know about transmission in New York City, what our data is showing us, and how we can really guide to keep folks safe in our jurisdiction. But just to sort of talk about our wins, and I'll take a step back just to sort of walk through our vaccine equity strategy. And so at the beginning of our vaccine rollout, we had already outlined the ways in which we wanted to advance an equity strategy within our vaccine distribution plan for the city. And part of that work has been building off of the work that we've already been doing during this pandemic. We also have an equity strategy that we rolled out and launched during this pandemic, really thinking about how we're using our data, how we're partnering with providers and community-based organizations, but certainly thinking about more investments in the neighborhoods so that we can really tailor our operations in neighborhoods that have been disproportionately impacted. And so that partnership has been really instrumental because of the city's coordination to launch what we know as our city's task force on racial inclusion and equity, marshaling resources across our city agencies to ensure that we are really thinking about all the needs that we can put forward to address the concerns of New Yorkers. So our vaccine equity strategy is built out in 4 pillars. We think about access, we think about uptake, we think about the outcomes, and we also ground that in another pillar called dismantle. Really thinking about how we can embed a sustainable process going forward. And so with access, we used our data intentionally to look at the communities that have been disproportionately impacted, while also matching that with very similar to CDC's social vulnerability index to really look at those indices that can expose individuals who are more likely to increase hospitalizations or death due to COVID-19. And so we increased and made sure that our access points in neighborhoods that have been disproportionately impacted by COVID received most of those access points, sites where we were vaccinating. Most of our city mass vac sites are in those neighborhoods. Then when we think about uptake, our organization. So it's not just about partnering, but also investing in these organizations so that they can fund and also hire staff and be well-resourced to do outreach and messaging. We talk about trusted messaging, trusted messengers, but how do you really resource and build their capacity? And so we did a lot of working with those organizations, but also bringing those organizations into the process so they can help us plan. The last two I think are really important. I think that also goes back to your first question about how do we really think about dismantling and really rooting out structural racism. We have to look at our data explicitly. As I talked about place earlier, we also look at age and race. And we have to think about our race explicit strategies in an intentional way so that we can think about how we're allocating our resources. We use our data to inform our operations, and that has to be part of the work. I think those are actionable areas to think about how we can make a declaration real. And last, dismantling. So I think very early on, we saw that there were a lot of unknown reporting for race and ethnicity. And I think we've seen this across the country in jurisdictions where counties were seeing their providers not reporting race and ethnicity. We see reporting race and ethnicity helping dismantle structural racism because we need to know how to inform our operations. And so at the beginning of our distribution rollout, 40% of the reports that were coming back were unknown with race and ethnicity. Today, we're below 10%. And that was dedicated work that we really need to do to work with those providers to ensure that they were reporting race and ethnicity so we can really understand where the disparities were, where the gaps are, and begin to push resources forward. Now, certainly we have more work to do. So I don't want to sugarcoat this. We have work to do to close the gap, but these are just some of the wins that I can talk about.
And yet, when we were chatting earlier, you mentioned two words that seem incongruous with this whole subject: hope and joy. What gives you hope and joy?
What gives me hope is that we continue to ground our planning and our operations with equity. And I think that's the opportunity, that it doesn't become just an acknowledgement, just doesn't become a conversation piece, but really, how do we make this actionable? How do we identify where the gaps are? How do we identify the communities that have been hardest hit, and making sure that we're marshaling our resources in those areas? And I certainly do not want to just say that New York City is doing this. We have been working with other health equity officers and health departments to really look at the way in which best practices are being rolled out. We see in Chicago, through their rapid response teams, being able to really bring resources in parts of Chicago. We also seen this in Vermont, where they explicitly use race as an indicator of how you should roll out your vaccine by prioritizing BIPOC individuals in the eligibility criteria. I think we have glimmers of these hope, but how do you standardize it? How do you make sure that reporting becomes the standard minimum in all of our electronic health records to ensure that we're capturing race and ethnicity and also gender and not just sex assigned at birth? I think that's the hope that I have. And certainly the joy is being able to do this great work and continually being reaffirmed that we're moving the needle.
Thank you, and sharing it with us. Before we do another round robin, I want to share a bit of new research that, in fact, was conducted by myself and my co-author, Benita Stewart. In December, we asked 2,300 American female desk workers across 4 races and 4 generations whether they had experienced additional stress on the job in 2020 as a result of the COVID-19 pandemic. And for the results, for Black women, 70% said greatly or somewhat increased stress, 72% for Latinx women, 60% for Asian women, and 67% for white women. So do you think, let's talk about this stress as we go forward this summer, as companies insist that their employees come back to their offices. Will that stress increase or decrease? Last week, I heard JP Morgan Chase CEO Jamie Dimon say that he expects 50% of his staff to be back in their offices by July 17th. Dr. Easterling, what should we be worried about more stress, or do you think the stress will come down as people get back to more or less normal?
I think we need to anticipate that there will be stress and tension associated with sort of the reemergence out of one's pandemic life and into society, interacting with others, public transportation. But, I think this is the opportunity. Now is the time to be having these conversations with employers, policymakers, and leaders to really think about our role, to really ensure that we are creating an environment of safety and wellness for staff, for communities. And that's what I think we can focus the conversation on. I think we do understand that there has been an increase in unmet mental health needs during this pandemic. One, because the infrastructure has really shifted and really have been singularly focused on COVID-19 and the pandemic and now the vaccines rollout. We also know that individuals have been lost to care and have not returned. And how do you reconnect individuals back to their primary care providers, their behavioral health providers, and ensuring that they are receiving the treatment that they were once on, but also thinking about that management going forward. But I think this is an opportunity for employers to sort of take this on as well. How are you supporting individuals to get vaccinated? But also really having a conversation about having supporting an informed decision to get vaccinated, but also creating spaces using art and exercise and meditation in ways to create a different environment. And so this is a time to have a different conversation than we were having in January and February of 2020. So we are not going back to business as usual. And I think that's what concerns staff the most. How are you protecting us?
And Ms. Krofa, who in these companies and schools should be thinking about the return to work? Who should be the chief medical officer?
I think it's the entire leadership of an organization, from the chief executive quite honestly. I was looking at Kaiser Family Foundation data just this morning, and the data at the end of the week, based on the number of sites reporting to the CDC, it's only about 55% that are reporting on racial and ethnic demographics. Only 9% of African Americans have received a COVID vaccine. We have a long way to go. And that we have about 64% for those reporting, shows that that's the white population that's received the vaccine. So when I think about from an employer perspective, maybe there are three things that we need to do. The first is education. What are these vaccines? Sharing information about safety and efficacy. I think, of course, as individuals get the vaccine and they see family members get vaccines, the confidence levels will increase. But we do need to continue the education and meeting people where they are. I think we need to show respect at an individual level to answer their questions and not just come with a stick, but also with a carrot. The second thing is we need to increase access and all access points. It is encouraging to see the different best practices happening across the country, whether we need to have mobile units, not have appointment-led vaccinations, but open sites, and those, of course, are popping up all over the country. Those will increase the opportunity for individuals to get the vaccine. And the third is an incentive. Create an incentive to get a vaccine. Rather than just a mandate, we mandate you to, we educate, we increase access points, and we create an incentive. Sometimes it just takes a little voucher. You come in, you get a $25 Amazon voucher. Many employers are doing this and are seeing vaccination levels increase. But all of that needs to come as part of the culture of a company, of an organization. It really cannot just be, we dictate that you do, but rather we're going to meet you where you are and provide the resources that we have at our disposal as an employer.
I just want to go back and make sure that I wrote down the numbers correctly, because I looked for this morning and couldn't find it. Only 9% of African Americans have received a vaccine, and 64% of white Americans have received a vaccine?
Yes. So the Kaiser Family Foundation data show that as of April 26th, the CDC reports for those sites that are reporting, again, it's just 55% that are reporting racial and ethnic data. Among that group, 2/3, 64% of white have received a vaccine, 12% Hispanic of that data have received a vaccine, 9% Black, 6% Asian, and 1% American Indian and Alaska Native.
Ay, ay, ay.
We have a long way to go.
Yeah, we do. Dr. Lewis Hall, we're talking about mental health. We're talking about re-entering society. Whose responsibility is it to deal with these mental health issues?
Well, it's all of our responsibility. And the effect of the COVID pandemic, if you include loss, isolation, illness, job loss, and a whole host of other stressors, managing childcare, travel, food security, you name it. There are a number of stressors that are affecting people every day. In fact, a recent report suggested that 4 in 10 adults reported anxiety or depressive symptoms in October of 2020, compared with about 1 in 10 in June of 2019. So kind of the COVID effect on these anxiety and depressive symptoms. In addition to that, about 36% of people agreed that they were having challenges with sleeping, 32% with eating, 12% with either ethanol and or substance use, and about 12% who already had conditions suggested that their condition was worsening. And as a friend of mine says, and for Black and Brown communities, it's a mo better problem. About 48% of Blacks suggested that they were having anxiety or depressed symptoms. So ponder that, that's nearly half. And about 46% of Latinos reported that they were having depression and anxiety symptoms. If you add those issues on top of the fact that oftentimes Blacks and Hispanics report lower capacity or lower access in a healthcare system to get mental health needs met, and the further disruption of our healthcare system. What Dr. Easterling said before about this, how are we going to get people into treatment, back on treatment they had before, into new treatment if their symptoms are not resolving? We have some very significant opportunities. I said it's everybody's responsibility, and here's why I said that. For those of us that are having symptoms, if you yourself are having symptoms, to make sure that you are talking to someone about that and asking for help. If you know someone who is having issues and is having difficulty, and help them how you can, referring in, making calls for them, facilitating them to treatment if they need the ability to get there. And then last but not least, as people who are working in the healthcare system, we are all working diligently to try and figure out how to open up our system and make it available to people who need it when they need it.
We're so used to making a way out of no way. Everyone talks about the resilience and the grit of people of color, and it may be keeping us from getting some of the treatment for these issues. Well, we've got one more big topic to discuss. It's sort of the elephant in the room. Do we need a health equity Manhattan Project, a top-down systemic reset of the entire healthcare delivery system in the United States? And that would include changes in medical and education and workplace and transportation and the government sectors as well. And of course, the questions are sort of obvious. Who suggests this Manhattan Project? Who coordinates it? Who pays for it? Who sets up the metrics to determine how and whether the remediations work? And since we're here with a Milken Center audience, should the Milken Center do some of this work? Should we just, again, do a round robin? Dr. Lewis Hall, do you want to start?
So, yes, I think one of the things that's been missing in really addressing this in a holistic way is that we haven't had a plan and we haven't had a leader, right? And sometimes leaders volunteer and sometimes they're voluntold. And I think that either one of those works. I was just looking at the Project Management Institute's kind of applaud, if you would, recognizing 50 projects that basically, change the world. Huge medical science that advances things, infrastructure projects, technology advances. And there were a lot of health-related things in there, including the Genome Project. We mentioned Dr. Collins earlier, who led this. And again, this is what happens if you bring all hands on deck. The public sector, the private sector, the not-for-profit organizations, people who are conveners, project managers. There's room for all of the skill sets that we have. We just need that galvanizing body to bring us together. And I've worked with the Milken Institute for years now, and I know that the leadership capacity there, you've seen it in action, and the ability to kind of put things on the road and make them happen is a part of what the Institute does. So I would look forward to having them, us, I guess, raise our hand and be ready to step up to do our part.
And maybe this webinar is the first step. Ms. Crofa?
Well, thank you so much by being voluntold by our board member as well, Dr. Frida Lewis Hall. I will say that it is all hands on deck approach, and we do need a plan. I mean, I really echo that sentiment. I have been pleased to see all of the various responses. We saw this starting last summer with the unfortunate death of George Floyd, and all of the statements coming out of every organization, small, large, multilateral, and the like, pledging their commitment to tackling, racial and inequities and disparities wherever they might be. And all of those organizations and entities and institutions are going about it in their own way, identifying pilot projects and identifying initiatives. All of that should be applauded. We should certainly continue all of that. But what we really need is a national plan. We need an effort where it is going to be sustained well past all the good sentiments, well past the corporate social responsibility, well beyond all the well-intentioned leaders, that is built into the fabric of this country. Because as we talked about, even when I referenced Dr. Collins' effort, we talked about tackling systemic racism. That racism is embedded in policies, it's embedded in practices, and that's why we need a comprehensive plan that I would suggest is actually started and led at the federal level. Bring all of the multi-agencies together to say, what are you going to do? We have seen that leadership through the Biden administration. We need to see it formalized, and we need to see funding that goes behind that.
Dr. Easterling, you described almost a patchwork approach that's already beginning. You talked about Vermont, you talked about New York City, you talked about Chicago. Could a federal umbrella plan capture the best of these local efforts and bring order somehow to them?
Yes, absolutely. And I totally agree with my esteemed panelists that if you're asking me for a national plan that is rooted in an intersectional anti-racist equity lens, then without question, because it provides a shared analysis that not only looks at our data and how we see the work that's ahead, but also rooted in Dr. Kamara Jones understands value in people and the historical injustices that have existed throughout this time in which the first person of African descent have landed on this country. Like, we really need to root it in the injustice that we understand, and not just starting with redlining, but we know that, the first person of African descent landed in this country involuntarily in 1619. And I think that then allows us to think about the work so it's not so mismatched, and what one jurisdiction is happening over the other. And we see this. CDC has put out the data on how the vaccine rollout is happening in certain jurisdictions, and certain parts like Louisiana and Alabama have counties where Black Alabamians are vaccinating more than others in those neighborhoods. What's different? What's happening there versus other counties and other jurisdictions? So I do think a shared plan. shared resources will really be important going forward.
We've been getting some fascinating questions. I've been looking over, and let me see if we can tackle some of these. Can the last 4 years of steady dismantling and defunding of childhood early prevention and treatment programs, federal programs, Medicaid programs, can they be turned around? And can we improve health equity by, let me scroll down, by focusing on childhood wellness in some impoverished communities? Is that the place to start? Or I mean, when you talk about prostate cancer and strokes and Alzheimer's, that's the other end of the age spectrum.
I'm happy to start, which I think we've actually begun to see some inroads here. When the Biden administration came in, they committed to strengthening the Affordable Care Act. Part of that strengthening was reopening the health insurance exchanges to allow those who lost their health insurance during COVID to regain that. And we're seeing significant uptake of insurance, which, as many people know, that's your first access into the healthcare system. We also know, of course, that Medicaid expansion has been on the table for quite some time. Since the passage of the Affordable Care Act, and there are a number of states who have not taken that up. Women and children, that's the primary place in many states where they have access to health insurance. So again, if we can expand Medicaid coverage, we can get more women and children into the health care system, and we can start at the very beginning of life, really to tackle those chronic conditions and underlying health conditions that we just talked about, how they affect you at the end of life. We're seeing some movement here, but certainly I would say for those states and entities that have not expanded Medicaid, we need to also put some emphasis there.
Anybody else?
I would like to add, I would absolutely want to focus on young people because you derive the benefit, but I don't think you can only do that. If we look, there are health disparities in every part of the life cycle. We've called it the effect from womb to tomb. And, being able to understand and start to address that, I think is really the way to go. But absolutely, we have to take care of our young ones so that they have long, healthy lives.
Right.
I totally agree. I was going to make a similar point, just really making sure that the roadmap towards equity obviously cannot just focus on one population, but we do have to sort of disaggregate and expand to make sure we're always asking the question, who stands to benefit the most, who's going to be most burdened, and how do we make sure that there's no wrong door? And we know that it's not just about investing in those programs. And if this vaccine rollout has not been clear enough, that it's really about the work of building trustworthiness. We know that if we build these programs, our communities are not feeling the trust and not feeling as though they're going to be really welcomed with these programs. So we really have to make sure that we're doing some of that early work, softening the ground, figuring out how we're really talking about the wholeness, the whole part of the family that we're really trying to support.
There's a provocative question here. Would we have seen and noticed focused on health equity during COVID without the Black Lives Matter movement occurring last year? Did the violent deaths of George Floyd and others wake up the country to the inequitable healthcare system? Any takers on that one?
I'll jump in, and I know this is a provocative question, and maybe I'll just respond it this way because I just picked up 400 Souls, and which is a collection of 90 writers, and Nicole Hannah Jordan talks about the very first section, what's classically American, and really this anthology of the history of African Americans in this country from 1619 to 2019, and so. Unfortunately, we would not have even existed in a moment. The reality is it would have happened. If it wasn't George, it was going to be someone else, a Breonna Taylor or Dante Wright. And that's the reality that we're living in and we're constantly facing. Now, the problem and the question is, how do we really make sure that we're meeting this moment and really responding in a way, not only within the healthcare space? And I know that we're talking about advancing this dream, but this is much broader in how we're reimagining our public health system, our public safety system, our education system, so we're not having these conversations on loop.
Someone asked me.
I'm sorry. Go ahead.
Someone asked me, is this a moment or a movement? Mm-hmm. And I said, it's up to you. Mm-hmm. Because I believe that you're given a moment, you turn it into a movement. And I think that many of the things that have happened since have really put us on the right road. My mother always said, do not let the storm distract you from your journey. Let it clear your path. And if this last year and a half hasn't brought our attention to things that needed to be attended to and cleared our way for the things that needed to be done, I don't know what would. So I think I agree. I think we would have come to this from a number of different directions, and I am just glad that we're here, ready to move on, take action, and make it better.
I'm getting the hook, even though we started a little bit late. We're going to end a little bit early. And Ms. Krofa, any final thoughts?
I would just agree. I think we have this crisis. Let us turn it into an opportunity. Let us continue to lock arms. Wherever you are, do your part. Don't look over the shoulder to someone else. And, we'll certainly do our part under the fantastic leadership that we have with our advisory group and many others in the community. Now is the time, and what a moment that we're in. Let us certainly take advantage of it to change lives, and I'm excited about that.
Thank you so much. I know I've learned a lot in this last hour, and I assume everyone who's listening in has as well. It was a spirited and very educational discussion. Thank you, Ms. Esther Krofa and Drs. Torian Easterling and Frida Lewis Hall. Now, I mentioned at the beginning that this is just the first webinar in a 4-part series. Look for details on the next webinar, which is going to be focused on financial health and the American dream, and that should be coming soon, probably next month. My name is Jacqueline Adams. Stay safe and have a great day.